Welcome back to Beyond Normal, brought to you by HealthSpan Chicago. I'm Dr. Tyler Saunders, board-certified internal medicine physician, founder of HealthSpan Chicago, a longevity-focused practice, primary care in Chicago's North Shore. Today we're talking about something that affects nearly half of American adults, and most don't even take it seriously because they don't really know anything's wrong. This is called hypertension or high blood pressure, the silent number some have referred it to. Here's what I find remarkable. In most clinical guidelines today, prevention of hypertension gets exactly one paragraph, which our guest shared with us before we started airing. The other 100 pages or so, talk about after it's already there. The gap between what medicine knows and what it actually prioritizes is exactly what this episode is about. My guest today, Dr. François Kaleta, we went to med school together at the Lake Erie College of Osteopathic Medicine. He's a cardiologist and a colleague I genuinely respect. He's completed internal medicine residency at East Carolina University and went to fellowship trained in cardiovascular disease at Penn State Health, Milton S. Hershey Medical Center. He's a cardiologist based here in Chicago, focusing on cardiovascular disease, hypertension, heart failure, and coronary artery disease. What I appreciate about Francois is that he thinks about hypertension in the way that I think about longevity medicine. Not just treating a number, but understanding what the number is doing to a person over decades and what it actually takes to change the trajectory. Francois, welcome to Beyond Normal.
Thanks for having me. Truly honored to be here. And I remember we were in medical school saying, gosh, we have to have a talk someday. It only took, 10 years to do?
Yeah, it's been a while, it seems like. I remember the first time we met, which actually was an anatomy lab. I don't know if you remember that specifically. And so, and I think we bonded over, if I'm not mistaken, a popular clip or from a like one of those memes or one of those videos, so which I think is pretty funny. Over the years we spent probably hours and hours together sitting in a small room studying, learning about things and really kind of diving into the physiology, and there weren't a lot of people that we went to school with that had the same kind of curiosity that we did, so I think it worked really well for us. But so we're gonna talk about hypertension, high blood pressure. We'll probably throw those terms around, kind of move it back and forth. I think this is something that there's a lot of people have, spoke out about this. There's a lot of things in our medical system that we're trying to attempt to improve this as much as possible. But we're here to kind of talk about the idea that your physician that you're seeing might not be the only person that can help you with this, and you're probably going to need to take some initiative to understand where you stand with this. And so we wanted to start the conversation off today with just a little history, figure out how did we even determine hypertension was a problem? And before we got on air, Francois mentioned maybe starting with FDR, who died at the age of 63. His blood pressure was 300 over 190, and how do we get from there to here in this conversation?
Yeah, I think the history is really important. It just makes you realize that it wasn't too far before we had a very archaic viewpoint on hypertension. I think that's actually where they came up with the term malignant hypertension, where their thoughts actually were, really don't treat it unless it's an issue, particularly heart failure, where I think even FDR was thrown on digitalis or digoxin as we formerly know it. And I think the death of one of our more storied presidents really brought attention to that, and it ultimately led to that major Framingham study in the 60s, where it was an observational study about hypertension and its effects. And I think it was quite revealing that, hypertension isn't something of arterial aging and just a benign process, and it's not. It's actually much more harmful early on, and obviously with that they didn't necessarily think they needed more research trials on that. And I think that's where the VA trials came in that showed that yes, treating hypertension early before it becomes malignant actually reduces your incidence of heart failure, stroke, and cardiovascular outcomes, and as well as mortality. And I think that that's a good point, because it was a late adoption. I think a lot of physicians who were trained, we shouldn't treat hypertension because that might actually worsen organs, and they need that blood pressure in someone who's aging. I thought that was actually very revealing, in my opinion.
Yeah, it's pretty interesting to see how we've gotten so far, and we went from, saying like this is a process, and you brought up the point malignant, which I think is interesting too, because we also used to use the term essential hypertension as well, meaning that it's essentially going to happen, right? And there's not really a lot we can do about it, right? And so we've gotten to the point now where we're saying, well, maybe if we address this sooner, we're not, like you were mentioning, worried about the accumulative risk of the damage that could be occurring over time. And so we'll talk about a little bit more about this now, but I think the next step would be, we have the history, like we realized maybe it's a problem, although we went from this isn't really a big issue into like, we need to aggressively treat this, and that fast forwards us all the way to the SPRINT trial from 2017. And then let's just talk a little bit about what blood pressure even is. I mean, a lot of people see two numbers and they say, well, there's two numbers. What do the numbers actually mean? Is one better than the other? Does it matter? Are we only worried about the top one? Like, explain to us kind of like what the numbers mean and where these even come from.
Yeah, so the top number, systolic blood pressure, is the peak pressure that the arterial system experiences after you have systole, or where the heart contracts, the aortic valve opens, and then the aorta receives all that blood. So it's really a more of a marker of how much stress is on the larger arterioles or in arteries. And then you have diastolic pressure, which is the highest pressure during the relaxation phase, where the blood then sloshes back and closes that major valve, the aortic valve. This one is more a manifestation of it can be affected by resistance and these smaller vessels. And contrary to what people think, the top number is not necessarily important in terms of cardiovascular outcomes in people, say, in their 50s and 60s, because actually elevated diastolic blood pressures is what drives cardiovascular outcomes before the age of 50. And how it goes is that the diastolic blood pressure plateaus around 50, 60 and actually decreases, while in the other direction is where systolic blood pressures continually rise. So after about 60, you get this widened pulse pressure, and then after around 60, then I start worrying about systolic blood pressures. So that's my approach, and I think that it's a slippery slope. You may have a patient's 130 over 85, but I think that's more of a worrisome sign than someone who maybe is 131 over 72. So, and someone who's younger, under 50.
So I think this is a really helpful way to think about blood pressure specifically, and I think a lot of times people don't exactly know what's happening when their blood pressure is being checked. Like, they've got two numbers and you're explaining what the numbers are, but essentially like you're putting a cuff on the people's arm and you're blocking the blood flow, and you relieve the pressure until you figure out the highest pressure, right? And then as that's slowly coming down, you start to figure out kind of more what the diastolic, or what we call the filling pressure, is. That's where the heart actually fills during that phase. And so I think it's good for people to understand and know, but like you mentioned, both numbers are important. The distance between the numbers are important. And so I think that's probably a good next step into talking about, like, what is a normal blood pressure? What's considered elevated blood pressure? And what's really important about this? So when you go to the doctor and you get these numbers, A, do they mean anything? B, what does it mean for you moving forward?
Yeah, so anything under 120 over 80 millimeters of mercury or less is considered normal. Certainly 120 to 129 over 80 or less is elevated. And then you get the stage 1, like 130 to 139 over 80 to 89 diastolic millimeters of mercury is stage 1. And then anything 140 over 90 across most guidelines or universally or more is considered stage 2 or, like, yes, treat this, please. So, with that, I think that, yes, that's the number, but, I think that this would be also a good time to discuss that to get the accurate number is very important. Not just the number, but in a busy office practice, you might be corralled into getting this number really quick. People might be talking to you, and then you're talking, elevating your blood pressure. And even, I just learned, a full bladder can increase your blood pressure by 10 to 15 points, which can make the difference between normal and hypertension, supposedly. So
yeah, and I mean, in those situations, like, you go to the doctor, a lot of times you haven't urinated yet because you might have to give a sample, so you're like waiting, right? And so it's like probably even more of a situation. And like, to build on that too, the how high your arm is up, for those people who are just listening, like, a couple of inches up will raise the blood pressure, and a couple inches down will change the blood pressure. And so, like, even these small things, like capturing the accurate number, like, we're going to talk about this a little bit more, and I kind of baited you a little bit into this, like, does that number even mean anything? You just ran up the stairs because you're late for your appointment, and then you go in there, and then you're talking, and then you have to talk about your medical history, and then there's a little bit of stress there, and you just had your coffee in the morning, and you still have to go to the bathroom, and maybe your feet aren't flat on the floor, and then by the time you get to it's like the number's not even a good number. And on top of that, when we go and talk about diagnosis, it's more than one number. You don't get a diagnosis with one number, right? You need more than a number. And so then what, I mean, I guess the question would be, like, how can we accurately check blood pressure? Now, at Healthspan Chicago, we have a specific way that we like to approach it, but I'm curious about, like, what's can someone do to actually understand what their real blood pressure is?
Great point. And, according to the hypertension guidelines, they're very clear when it comes to, if you feel that this is not accurate, with all these measures and they're still elevated, I think it's not just to say stop there and treat. Just like anything in medicine, we're always taught, is this accurate? Is this test accurate? What are the pitfalls and, that are caveats that we need to think of? And you just listed all these. I'll never forget, even before that, you sent me that article at AHA, I think, years back, on the picture of how do we to get an accurate office blood pressure, or just in general. Feet flat on the ground, sitting up tall, no exercise, nicotine, or caffeine 30 minutes prior. No talking. Talking can add 5 to 10 points. Even when I go to appointments or when I've had screenings through work, people are talking to me. I'm like, I'm not talking. I'm not going to add any more points. So there's all this. And with that, I think it's important to at least get home blood pressure monitoring if you don't think it's accurate. And they say get 2 readings in the morning, 1 minute apart, and then 2 readings in the evening, 1 minute apart respectively, for 7 days. You don't need to do a log for the last 3 years. It's too much data, but I think that gives an accurate representation of how you are in the morning and evening. Is there any discrepancies between the two? Also, doing 20 blood pressures in a row may falsely lower your pressure. Like, doc, it's elevated, but then the 20th one, I'm normal. So, and then they also say getting blood pressures on both arms and taking the higher of the two. Yeah. And that's, in the sense of the office and home blood pressure monitoring. And, I think that they also say that using these devices, the automatic blood pressure cuffs, are a little bit more validated than the discrepancy of the oscillatory, where we hear it, with the standard stethoscope versus the oscillometric, which is a little bit more accurate and takes the human error out of it.
Yeah. I mean, I think there's so many ways to go with this. But I think, like, having this, like, set the stage and people understand the way that we're going to approach blood pressure at HealthSpan Chicago is focused on a couple of different methods. And essentially one is what you described, and that's like taking 2 to 4 blood pressures daily for a period of time, somewhere between 7 to 14 days. I think 14 days is a lot, but if you want to get a good idea of what your average blood pressure is, you need a lot of data points. And you don't sleep well the night before, you have a really big meal, or there's so many things that can throw it off. And so you're really interested in the average. And if you go to the doctor and your blood pressure is high and they say you need a blood pressure medication, you're saying, okay, well, now you have one data point that you're going off of. What if your blood pressure is high because it's situational, which we'll talk about here in a moment, versus something else? Should it be treated with medication or not? And the other way that, I've been in conversation with trying to determine whether this is an appropriate thing to do is, I brought up the sprint trial before. I'm going to bring it up again for this scenario because this is kind of where we base our decisions off. This is where Dr. Kaleta pointed out 120 over 80. Where did this come from? This came from thousands and thousands of patients being trialed through this really large trial, finding that essentially lower is better to a certain extent, right? We can talk about low blood pressure at some point, but that under 120 over 80 is better. How did they collect those blood pressures? So if we clinically are trying to compare our blood pressures that we're getting to these numbers, we should measure them similarly. I think that's a very fair and logical way to approach it. And the way they did it is they'd sit someone down, wait 5 minutes, they'd do everything that we had mentioned thus far. They would take a pressure, they'd wait 5 minutes, they'd take a pressure, they'd wait 5 minutes. Now this is like a long thing, and most doctors' offices aren't going to have the time to do this, but that's what we're comparing our numbers to, right? So we want to get something that's as real as possible in order to do that. And so that's another thing for me clinically. I'm saying, well, maybe that's the way we should be doing pressures. And in my practice, I'm fortunate enough to have the time to be able to do that and say, maybe these are 2 very valuable options to be able to approach it. Before we get into some of the other ways, I would like to talk about what is white coat hypertension. A lot of people have heard this term, or masked hypertension, and why does it matter in the context of this conversation?
Yeah, I think in this context, it's very important because if you don't have that regimented approach, and proud to say my residency was one of the sites at the sprint trial. Dr. Powell used to always drill this, so I trained under a hypertension expert who was the awesome. PI of that site. So, and he was always saying that we got to do this. He was educating the medical assistants and nurses to do that protocol, and it was a very arduous and rigorous process, and they were very proud of that. And if you don't have that, I think this is where you might start getting patients that have the white coat hypertension to start with, that are elevated at the office setting but normal at home. And you could say, okay, well, it's just white coat. I'm scared of this. So, I'm fine. Well, studies have showed that, you're at higher risk of having hypertension or essential, and down the road, and increased cardiovascular risk. So, I think this is where arduous home blood pressure monitoring and lifestyle intervention early on is really important. And actually, another thing to think about is there's the prevent scoring system that, if they are over 130 over 80 based on the guidelines, you could do the scoring system, which is a little bit more expanded from the age of 30 to 79 instead of 40 to 79 with the pull cohorts equation that captures more people and also has some metabolic risk factors. And then the other thing that you mentioned was masked hypertension. I think this is a little bit more sinuous because you have patients who have normal blood pressures in the office, but you're missing the blind spot of being elevated at home. Particularly, maybe you're seeing them in the morning where they're okay, but they're having elevated blood pressures at night, or non-dippers. And this has even higher risk of cardiovascular outcomes, or risk. And, I think that's a blind spot we miss. And furthermore, they say in the guidelines 10 to 15% of patients with hypertension have masked hypertension. So this is something that's totally undiagnosed, and we're dropping the ball on this, and most of us.
Once again, there's so many different ways we can go with this. I mean,
yeah.
This is one of those things. I mean, it's just like you find this, that, and the other thing. And the reality of it is, it's like, it's really not that hard to find these things if we have a very structured way of doing it. You do have to invest time in doing it, but we're talking about this is a big deal. I was gonna throw this statistic out there, but every increase in the systolic of 20 or diastolic of 10 doubles all-cause mortality. Okay, and so I'm going to let that digest a little bit. What does all-cause mortality mean? It essentially means your risk of dying from anything, not just heart disease, not just stroke, not just any of these things. And that is double. This is like a logarithmic scale, which I know is hard to conceptualize, but every time it goes up that high, it's a doubling. This is not something that's, trivial, but a lot of people, especially in the longevity community, are looking for the latest and greatest, whether it's the drug that's going to make you live longer and these types of things. What I'm saying is what percentage of people actually have good evaluation of their blood pressure to understand where they actually stand? And you brought up the prevent calculation, and I think it's really important for people to understand. We use this calculator to help assess people's risk for predominantly cardiovascular disease, and it's gotten better than it was before. There's still definitely holes in it, but something as simple as a blood pressure of 130 over 80 kind of gives you negative points, so to speak, or a higher percentage of having a heart attack or stroke. And that blood pressure it's not that bad, but then you sit back and look at it and say, well, it actually is pretty bad, right? And so I think then that kind of drives us into the next thing, is we have all of these different ways of testing it. One thing we talked about off air too a little bit was, what's the role of ambulatory blood pressure monitoring? What is that, and why is it not really used?
Yeah, that's a great point. Every time you read about hypertension, the evaluation, these landmark trials, also guidelines, they overwhelmingly say that ambulatory blood pressure monitoring, ABPM, is the gold standard to evaluate for blood pressure. So as a disclaimer, my residency, fellowship, and even where I work does not have these devices. They're not fairly expensive. They're around $1,000 to $2,000 depending on the vendor you use, but that may be a barrier why they don't have it in most institutions, and possibly because of reimbursement rates. However, they give you a wonderful set of data. So typically, what I view it as a cardiologist, it's like the Holter monitor equivalent, like where they monitor your rhythm. Instead, they give you a blood pressure cuff on the right arm, and then you have a device. And every 20 to 30 minutes, I think as a physician, we can set that timing. And with that, it gets you daytime blood pressure, nighttime blood pressure, and everything in between. And what you can get is a 24-hour blood pressure, which typically it's 115 over 75 is less, or less than is normal. So it's a little bit lower goal. And blood pressure at night is also lower, like 110s over 60. And the thing is, or maybe 65, I have to double check. But essentially, the things you can look for are, is there any hypertension or elevation of blood pressure during the day, during the night? And there's the term, so this can capture, put the rest, white coat hypertension. So if it's normal, the 24 hours, then you're reassured this patient's okay. And there was just anxiety or all those factors we talked about. Masked hypertension, where it's actually very bad and elevated throughout the day or even worse at night. It could show the non-dippers. So typically we should have a 10 to 20% drop of blood pressure at night, nocturnally. And if you don't, that's a risk factor in itself. And also it can tell you about early risers that have been showed linked to stroke, which is very concerning. So all this can be picked up, and this is particularly in people who you suspected those conditions, or suspect even people in treatment, that can allow you to see what you're not seeing. Potentially maybe not coverage at night, where you got to split the medications, maybe some at the day, some at night for coverage.
Yeah, we've mentioned this dipping a couple of times. There's really no other way of testing for it. And essentially at night, you think about, why does your blood pressure lower? Well, I think it's multiple fold. One, like, you don't need as much pressure to send blood in a flat person than a standing person. I think that's just logical, right? The other side of it is that you get increased vagal tone, or less sympathetic tone when you're sleeping. At least you should be, because if you're not, your sleep quality's down too. And so you're getting a better idea of what's going on with the person, because your blood pressure at night actually is lower. And so we've had a couple of conversations about this, and like, reimbursement is essentially not there. When I came out of residency and I was like reading about ABMPs, the ambulatory, and like, no one does them. And you're like, why doesn't anyone do them? They're kind of arduous, and the insurance doesn't pay for it. And so then you say, well, do I need to find somewhere to do that, or do I need to do some of these other alternatives we're talking about? And I think like the next best thing is having multiple days of recordings as much as possible to get a really true average, knowing that you might not capture these things. The other part of it too is, we're not going to talk much about treatment right now, but taking medication at night, I'm actually kind of curious about your thoughts of this, so we could take a little bit of a detour in that if you don't know if your blood pressure is going down or not, there is some evidence that taking your blood pressure at night was a positive thing versus earlier in the day. Now, it probably matters on the medication you're taking, but there's some data to suggest that, so maybe that's a little bit simpler of a solution, too. So I'm curious of what you think about that.
Yeah, I think the current guidelines don't really, they say you can just do it during the day. There's no difference. There was I can't remember, I think it's time trial, I can't remember, but they studied this, and there was no statistical significance, I believe. Now, there may be other trials I'm not aware of that showed any benefit nocturnally versus daytime. However, like you mentioned, sometimes if we're dealing with side effects, this might be something we consider putting that during the nighttime. Certainly, I wouldn't want diuretics, because if I do that, my patients aren't going to come back to me, or just be very upset that they're going to the bathroom, having a lack of sleep, and that can cause your blood pressure to be elevated too.
Yeah. So I think it's probably a good time to talk about why do we really even care about the blood pressure being elevated? We know it's bad. We know the data says it's bad, but what is it really doing? Like, what is blood pressure doing to the blood vessels that, and what is it doing to the body, and why is it such a problem?
Yeah, so, part of the thing that I do as a cardiologist, if someone's being sent to me, is I look at the whole picture. I think that is also what we learned in osteopathic medical school, is not just the body, but the mind and the whole picture of everybody. So taking a holistic approach, you not just see the number of the blood pressure as your vital sign, but also what do their labs show? Is there end organ damage? So particularly, like you mentioned, vessels, well, things that we can't test for, but obviously you get cholesterol, but you get those lipohyalinosis of the small arterioles, and then also diabetes, which is an inflammatory condition. So that increases your acylated glycolytic end products, and all this leads to atherosclerosis, stiffening the arteries, and then that leads to further inflammation and worsening. This can also in turn lead to glomerular hypertension, or elevated pressures in the glomerulus. That is basically the filter of the kidneys, and that can lead to protein leakage, where we do a urine albumin creatinine ratio. That can lead to serum creatinine elevation, or chronic kidney disease. And then that can lead to electrolyte abnormalities. From a heart standpoint, I always get an EKG, and the things I look for are basically thickening the heart, particularly the left side of the heart, left ventricle. That's your big chamber. And so what we're looking for is big, tall complexes, or what we call QRSs, and that leads to thinking maybe there is hypertrophy of those ventricles, or LVH. There's also things that we look for as infarct or possible areas of dead tissue. Not everybody feels heart attacks, particularly diabetics, older individuals, females. And so we don't want to miss that, and that changes my workup. Or AFib. So if you have, which I'll talk to in a second, so if that happens, we get an echo. So in echo, we look for dilated left ventricles, so our big chambers. Are the chambers thickened? I tell my patients it's like working out. So if your heart is feeling high pressures all the time, it's going to experience hypertrophy. And you would think that that's good, but actually thickened hearts or hypercontractile ventricles actually lead to worse outcomes. And we can't even use some medications because they say that increases mortality in these patients. That in turn leads to diastolic dysfunction, in English, stiff hearts. And then that leads to backflow to the chamber, what we call the atria, which is like the meeting area. So all the blood that is oxygenated from the lungs go to that chamber, and then it's waiting to then go to the left ventricle, and then it pumps out to the rest of the body. What happens if you have a stiff left ventricle, those pressures build up, and then that dilates, and you get AFib. So you have all these manifestations that can happen, and I particularly like echoes so I can see that. If I see this, then that's a problem, we need to treat it. And studies show that if you treat hypertension, a lot of that can regress, believe it or not. Like 60%, I think, that those thickness can actually reduce to even normal if you do aggressive treatment, say through the SPRINT trial.
And I think a good point to kind of piggyback off of that is blood pressure is a functional problem, right? It's not a structural problem, but it creates structural problems with long persistence, right? And that's where we need to be really concerned about it, and that like all of the organs that are impacted greatly by blood pressure are the ones with the tiny, tiny little blood vessels that require a lot of blood flow. Heart, brain, kidneys, right? And so, I mean, the kidneys are a really good example. They make up, I think, like 1% to 2% of your body weight, and they take about 20 to 25% of your cardiac output, which is the amount of blood that you're pumping out of your heart, right? And so kind of a disproportional amount of, and so if your blood pressure is constantly high all the time, those tiny, tiny little vessels, as you mentioned in the glomerulus of the kidney, they suffer over time. Now, fortunately, the kidneys are very redundant, meaning you could take one out and have normal kidney function. Unfortunately, the heart and the brain don't quite have that luxury, right? But at the same time, like when we're thinking about these tiny vessels being affected, I think it's really important. We have a conversation about cardiovascular disease, heart attacks, strokes, and things of that nature all the time. And there's only really 3 things that are known to cause heart attacks. Now, a lot of things contribute, yes. Blood pressure is being one of them, and I think a lot is being left on the table if talking about what we're talking about. And the other ones are like smoking and then apolipoprotein B. Like these are the 3 things we know cause heart disease, and I think a lot of times we get caught up in what is the cholesterol, and we get caught up in some of these other things. We have an opportunity here to identify not only a functional problem with the appropriate testing, we have an opportunity to identify structural change as a result of that, and we have an opportunity to stop it. And we have a lot of good evidence to say medication will essentially, as you mentioned, reverse a lot of these changes. The sooner we, approach it, the better, but at the same time. And so I think this is probably a good transition point for us here, and that saying like, well, we know it's bad, we know it's causing a lot of damage, so what do we do, right? And I think the first thing the guidelines state, the first thing that we do in practice is we evaluate what's the number in the context of the individual. How can we use lifestyle intervention to improve this? And so I think it's a really good place to kind of move into that. So walk me kind of through your thought process and how you're thinking, if you have somebody in that elevated blood pressure range, so we're talking about that 120 to 129, range, like, what are we thinking? We're not thinking, we need to do meds now. We're thinking, what tools can we use to lower their blood pressure before we have to go to medications?
Yeah. And one thing before we go further, the one thing we might want to mention is the studies are very clear on Sprint Mind trial that although they didn't have it long enough for dementia, but 40 to 50 is where you must treat the blood pressure, otherwise higher incidence of dementia, particularly vascular, because of small vessel strokes. So the problem with all this is, how do we motivate people when they don't feel bad right now? But like you mentioned, these interventions that we can do, which I try to do myself, help with that. I think one thing is very clear. You can get 1 millimeter of mercury reduction for every 1 kilogram of weight above ideal body weight. So that's a really good motivator. If you lose substantial amount of weight, that might be as enough as that of one blood pressure pill. So that's one. Exercise, you can expect 4 to 8 millimeters mercury aerobic. I think isometric, I think it was like 2 to 3 millimeters mercury. Mm-hmm. Although sometimes I wonder, like we were talking in pathology all the time, endurance leads to volumetric or increase in the heart size, but weightlifting leads to concentric thickening. And I don't know if they've clearly studied this, but I always wondered, is that really ideal? But there are some studies that show that can lower pressure, but maybe just don't overdo on the Valsalva. Also, if you are motivated, you can do things like meditation, which is in the guidelines, that there's studies showing that, yes, that can help. But I think they're very clear that this isn't a replacement to treatment if, say, the prevent score is high or you're starting to see end organ damage. And it has to be someone who's motivated, that's doing this consistently.
And this is the, for me, it's like everything that we try to do at HealthSpan Chicago is focused on making it easier to create consistency. And it goes across the board from everything in health, and that if we can create consistency, we can get these what appear to be small reductions, but they really do matter in the long run. And that, the data that shows any type of exercise helps your blood pressure, right? I still remember I laughed when you mentioned the type of heart changes, because I remember sitting in school reading our physiology book and saying, is this a good thing or a bad thing, right? But the reality is this exercise improves blood pressure regardless of what type it is, and you would expect all of the bodybuilders and powerlifters to have hypertension if lifting causes hypertension, which they don't, right? And so then that kind of is an interesting question. I think you kind of summed it up really well. It's like weight loss is just as effective as a blood pressure medication. Now, that's not always easy for people to do, but exercise, which helps you, change your body composition, is a tried and true way of doing it. Anything that's going to decrease your kind of, I guess I don't want to use the word anxiety, but kind of calm your body down is going to help. And then, some of the basic stuff, we talk about the foundations of lifestyle, like sleep, for example. You can see an increase in your blood pressure just after a poor night's sleep. And so if you're consistently sleeping poor, the data suggests under 5 hours or over 10 hours consistently is associated with very large increases in blood pressure. And so we need to think about all of these things. And I would be remiss if we didn't comment on sodium. This is always an interesting conversation. I don't necessarily agree with the guidelines on this, because I find that some people are salt sensitive and some people are not. People that are metabolically unhealthy are more likely to have salt sensitivity. And so doing kind of a blanket statement and telling no one to eat salt all the time does create problems. And I will tell you clinically, I've seen this many, many times. I've seen where the husband in the relationship has high blood pressure, and the wife in the relationship cooks most of the meals, and she doesn't use salt because she's worried about her husband's blood pressure, and then she comes to me because she has a bunch of cramps in her legs and she's lightheaded, and so she's not eating enough salt for her in order to make, and it's just kind of an interesting thing. It's like not everybody needs to have very little salt. The guidelines say lower salt because the average American eats probably upwards of 4 grams, but if you're being somewhat conscious and eating real food, you oftentimes actually do have to add some salt. And if you don't eat any salt at all, or very low salt, under a gram, there's actually some evidence that that could be bad for some people. So I'm not sure if you have thoughts on that. Like I said, I don't necessarily agree with the guidelines on this. This is where we take a more personalized approach for an individual, and if we're getting the blood pressures we need and we make these adjustments, we can see how that individual person responds, as opposed to kind of just saying, you're not allowed to have any salt.
Yeah, I think it's tough because, maybe most people probably are having so much sodium that maybe most people should not consume so much.
Yeah.
And I did like how this one hypertension experts thought of it as a debit card, where you get a refill every day of like 2 grams or 2,000 milligrams of sodium. And that's all you can use. So basically a teaspoon of salt, and that's it that you can add. And if you go over, there's hefty overdraft penalties. So as in high blood pressure and outcomes. But like you said, there are instances where, I have patients who have POTS who, if you look on the electrophysiology guidelines, see you can increase to 10 to 12 grams a day in order to maintain a normal blood pressure, because in their case, they may have an overactive or sympathetic dysregulation where they need the blood pressure, and you leverage salt to help increase. But most people don't fall in that. So yeah, I think an individualized approach is probably the most ideal.
Yeah. And for the audience, POTS is a long-term postural orthostatic tachycardia syndrome. You don't necessarily need to know what that is, but the reality is your blood pressure is low, and it gets worse when you stand up. And we've all felt that feeling when we kind of stand up too quickly, a little lightheaded, and that is an indication, some people would say, of dehydration. You could also argue that there's not enough volume, not enough fluid, that could be related to the amount of salt taken in. So I think it's a very interesting conversation, and it really depends on the person. And I have a biased approach in my patient population as well, in that, like, I have patients that are exercising multiple hours per week, right? And maybe even doing sauna therapy, heat therapy. Like, this is different. This is a different conversation than somebody who's eating microwaved meals, excessive amounts of bread, and things of that nature. So so in terms of the lifestyle, I mean, we can belabor this for hours and hours for sure. I think the interesting thing, and the thing to note more than anything else, unlike cholesterol in a lot of instances, blood pressure, lifestyle is a very, very strong tool. And in most people, you can get improvements in blood pressure with lifestyle, but it needs to be created around consistency and the main fundamentals that we talk about all the time: sleep, stress, diet, movement, right? And how you're approaching those things, which I think is really refreshing for people to hear, because most people don't want to start a new medication. I get that. But at the same time, blood pressure is one of those things. I like to give patients the opportunity to create that consistency and see if we can. And I will tell you that about, half of the people that are in that situation don't need to be in a medication. But the other half probably do, even if they're doing all of the things perfectly well, because there is a key genetic component to this.
Yeah, and I think that was well said. One thing to also add to this is, this is all cumulative. It's like you said, every little thing, maybe a few points here, a few points there, a reduction, that helps. So being healthy. Also, one thing to mention is sitting versus standing. And there's very clear outcomes in cardiovascular outcomes that if you sit less than 4 hours, your outcomes, your risk of cardiovascular events is substantially reduced. And then they did further studies that show, okay, not just standing, but what are you doing when you're standing? Are you just standing there? Well, you're going to get varicose veins. Or are you active and you're moving around?
Right.
A particular example is when I take my children to the park, I see a lot of individuals that are missing this wonderful opportunity running around with their young kids, be staying healthy, and that's one phase of someone's life, versus sitting down on the phone disengaged. So I think it is like a holistic approach that, are you taking advantage of any little chance you can stand and break up the day? I mean, sometimes we have to sit, we have to chart in our job, but I mean, in any job, you could stand, maybe take the stairs. These little things matter.
Yeah, for sure. So I think we could, like you said, we talk about lifestyle probably for another 3 hours, but it's a really strong lever in blood pressure, and I think that's refreshing for people to hear, because I think a lot of times, like with cholesterol, they talk about it, and they're like, I tell patients, I'm like, here's the limited things we can try, and if it works, great. If it doesn't, then this is the situation we're in. Blood pressure is not necessarily like that. I'm not saying it's easy to make those changes consistently, but like that's kind of the foundation and the way that I want to think about it. I want to make it as easy as possible for patients to make that change and be the support they need to make it. So when it doesn't work, I guess is then the next question. They're talking about medications, what we have we have a kind of a framework in the way we look at this from our practice. I'm curious about kind of how you approach it, how you're kind of risk stratifying people. Are you treating people based purely on a number, or what are you doing? And then how do you even decide? There's so many blood pressure medications. How do you even decide what's a good fit for an individual?
Yeah, so I think unfortunately for me as a cardiologist, by the time I see a patient, it's almost already too late, unless I see them for some other reason, say their cholesterol's high. I think also people know that like I am big on prevention, so people start sending me sooner, which is great. But if I see signs of end organ damage, you don't have to calculate the prevent score. You go straight to, like, if they have CKD, diabetes, history of stroke, atherosclerotic event, then we certainly want to consider treating. Particularly if their blood pressure is over 140 or over 90 millimeters of mercury higher. How I approach this? Well, unfortunately, I get a lot of patients who come to me who are on beta blockers. And, this might be JNC 7 recommendations. Unfortunately, that still goes on, and we really shouldn't be doing beta blockers, because we're talking about healthy lifestyle, exercise, and what better way to decrease that motivation to give somebody lower heart rate, lower stroke volume, decreased energy, nightmares, which they have their role in heart failure and other conditions, but for most people, that is not something we need to be thinking about. And based on that original ALHADS landmark trial that showed, this classic thiazide diuretics or water pills are no different, and not, there's no superiority between that and like calcium, non-dihydropyridine calcium channel blockers. It's like things like amlodipine or nifedipine, maybe people have heard of, and then also ACE inhibitors or angiotensin receptor blockers. Keep in mind, though, that in that trial, it was interesting that there was more heart failure events on calcium channel blockers. So, if it's like someone that has pure systolic hypertension, I think calcium channel blockers are great because you don't really have to monitor renal function. It might be a lifestyle. Thiazide diuretics can make you pee more. And obviously natriuresis are peeing out sodium. If they have a job where they don't have access to a bathroom, they may not take it. And we have to work around that for adherence sake. And then, usually most people kind of go towards like a lisinopril or ACE inhibitor or ARB, like losartan, valsartan, candesartan. And I think those are the three pillars that really are something that we need to consider based on blood pressure reduction. Certainly those two, the thiazide diuretics or thiazide-like and the ACE inhibitors and ARBs, need follow-up blood work. We could talk about the resistant, but those are the first three that I think about.
Yeah, and that's the way we approach it too. I mean, I have had a preference for the angiotensin receptor blockers or ARBs over the ACE inhibitors and even the others for that matter, mostly because checking labs to make sure things are okay, I think, is not a huge ask, but changing someone's lifestyle through water pills or things of that nature is something that we need to be considerate of, right? I think sometimes it's good for a person to know the drug is doing something, right? Because you don't feel the blood pressure, and so if you don't know it's doing anything, the motivation to take it is a little bit more, it's a little lower, right? And so without boring everybody about the different types of medications, these are the names of the medications you're going to hear. And these are the types of questions, especially when you're seeing your physician, and say, you need to be asking the question, why? Why are you considering this versus something else? And that's kind of part of the point of why we have these discussions and why I'm doing the podcast. It's the education piece is, why would you pick one versus the other, right? And I've seen the same thing. I've seen many patients that have been on beta blockers for years, and they're tired, and they can't get an erection, and all these other things, and they're saying, I don't feel good, and I'm saying exercise, and they're like, well, that's the last thing I want to do because I'm so tired all the time. And so there's a time and a place, and I think understanding what you're taking and why you're taking it is really important, and kind of empowering yourself to understand this is a very important thing for me because of X, Y, and Z, and I'm taking this for this specific reason, because the medication doesn't work if you don't take it. And generally speaking, a little bit over half of patients don't take medications as prescribed, and the big question becomes why, right? And that's something that I've thought about for many years. And what's the question about it? Is it a trust question? Is it a lack of understanding question? Is it an inconvenience question, right? And I think we always want to revisit this and say, uncontrolled high blood pressure is a cumulative effect. And I'm going to piggyback off of what you were saying earlier, in that, like, this isn't like you can have it for 5 years and then the effect goes away, right? This is a cumulative effect over years. If you have high blood pressure for a long time, for a very high blood pressure, it can cause a problem. And you've probably seen this, and I've seen it too. I've seen it more in men than in women. You see a male in his mid to late 40s on dialysis because his kidneys are completely shot because he's had super high blood pressure and it's never actually been tested, or it has been tested and hasn't been treated, right? And so those effects build up. And the medications work, and the side effects are relatively low, and so having an understanding of what it is, why you're doing it, what the upside and downside is kind of the centerfold of the way that I like to practice medicine. And I think as a patient, you should be asking those questions and understanding it so that you are completely on board with what you're doing and why you're doing it.
Yeah, well said. And just to add to that, I was always taught from Dr. Powell and at ECU when I was in my residency that, the first thing they ask patients that come for resistant hypertension, meaning that they have to be on 3 medications, and one of it has to be a thiazide diuretic. The first thing you ask, are you taking your meds? And it's very consistent. I would say half or even more, it's because of non-adherence. And like you said, maybe also they just don't think it might help, or they're not feeling bad, so why take all these medications? But I think it's very clear that, not to focus on numbers, but getting the blood pressure, particularly a motivated patient with clinically stable labs, that sprint trial, getting 120 or 80 or less is ideal. I think that's something that needs to make sure that if you are unsure, always bring it up. Particularly people who are open. I'm always open to discussing that with patients.
Yeah, and So we'll transition a little bit into something that I think I get a lot of questions about this clinically. You may not see them as often. Is what's the role of supplements in blood pressure control? And so I'll speak to this a little bit. We talked a little bit offline to this as to, can we use supplements to control elevated blood pressure? In short, the answer is maybe, right? Which isn't not a very satisfying answer, but the reality is we have data on certain products and we have certain ways of approaching using them that can lower blood pressure, but comparatively to compare to like weight loss, exercise, sleep hygiene, stress reduction, and medication, they oftentimes don't compare. And I've seen people before that aren't interested in any type of pharmacology, any type of medication. And so we start to think about ways and strategies to approach this. I'm not going to spend a lot of time on this, but for people that are interested, there's plenty of resources to evaluate this. Magnesium is something that's actually been fairly well studied. It can lower the blood pressure. We're talking about 4 millimeters of mercury systolic, 2 of diastolic, which compared to what Dr. Kaleta was mentioning about the exercise or weight loss, comparatively it's like a tiny little change. But with magnesium, it has to be a non-oxide version of magnesium, like a magnesium glycinate or magnesium threonate. And oftentimes the dose has to be, I think it's about 6 milligrams per kilogram, which for like a 150-pound person, give or take, it's like 450 milligrams. And so once you started to get that like 400, 500, 600 range, now you're starting to potentially see changes in bowel movements, and it can cause diarrhea and whatnot. So you have to be aware and think about these things. A couple of the other things that have been studied, coenzyme Q10 has been shown benefit only in people that have low serum levels of it. And so this isn't tested routinely, nor is it used routinely for blood pressure for that reason. Fiber, this is one of those things, not a supplement. There's plenty of data on getting adequate fiber, and we're going to have an episode about nutrition a little bit more, so I'll talk about fiber a lot more. Most people do not have enough fiber, but 30 grams of fiber per day, regardless of what type, are associated with better lowering of blood pressure than pretty much any supplement. And the average person in the US eats 7 to 10 grams of fiber per day. And so you want to make small changes that don't require medications, this is a very small change. Flax specifically has been associated with lower blood pressure in terms of the fiber and potentially the omega-3 content. And so, there are small things that you can do that, like we said, lifestyle is a really big thing here. I would not hang my hat on supplements to be the only thing. I've tried this clinically, I will tell you, and because patients weren't interested in medications, and I said, we need to do something, because if we let the blood pressure stay high, and I found to be, it's not super successful unless you have the consistent lifestyle change that people are bringing to the table.
Yeah, and I think also to mention, in addition to what you've said, one other thing that can help potentially, if you're somebody that doesn't have these risk factors, can be potassium replacement. Believe it or not, there's a salt substitute, and it's partial salt, because it turns out if you do pure potassium chloride, it's too metallic, so it's not palatable. But there is blends that most stores sell, and actually I was thinking about even doing that for myself. I think it's 3 to 5 points reduction, particularly in these salt-sensitive individuals. And then I think there is some data on beet juice, and also some omega-3s can give small reduction. I think it's better than nothing, but I view it as in a holistic approach, that all these things add up. A few points here, a few points there. Yeah. It's like a penny saved is a penny earned, or a point saved is a point earned, That might be one less blood pressure medication you need, or maybe hold off for a little bit.
Right. And, you bring up a good point, all these things, with beetroot, for example, eat the beet. Eat the vegetables. The reason beets are considered something to be helpful is because they have a large amount of L-arginine, which is associated with nitric oxide synthesis, and nitric oxide causes dilation of the blood vessels, which is the opposite of blood pressure, right? And as we age, we know this declines, and so we're saying how do I get more nitric oxide? There's plenty of supplements on the market, which I will say I don't necessarily know if they work. I don't necessarily, but can you eat more beets? Can you eat more fiber? Can you eat more flax? Can you eat more? Where's magnesium come from? Vegetables. Like, can you eat more vegetables? Can you eat more fatty fish, like the omega-3s you're talking about? Like, you don't need the supplements in order to do this. You can augment your diet with these things, including, and like you said, a little bit of less salt for certain individuals, a little more potassium. Where's potassium come from? Well, it comes from predominantly vegetables and some fruits. And so we're talking about, we didn't talk about this yet, we're talking about the DASH diet essentially. It's a diet created around the idea that we're going to do a Mediterranean-style diet focused specifically on blood pressure, and that, as it turns out, is very effective. And so I would say supplements are there potentially as something to augment what you're already doing, but there's so many different tools here that I think, like, we started this conversation off very doom and gloom because it's so undertreated, blood pressure is, but there's so much potential here for creating consistency, whether it's through lifestyle or even just through a medication, to control this and almost completely mitigate the risk.
Yeah, and increasing all these vegetables is going to up your fiber. So it's all it could be additive or combination, and that will increase your potassium intake too if you eat squash or things like that. And one thing to add is talk about doom and gloom. When you read these trials or the cohort for Framingham, that 90% prevalence of hypertension by, I think, age 70, which can feel a little dissatisfying, and I see it as a challenge, like challenge accepted. I'm not going to get hypertension, or at least I'll try my best.
Right.
But, there are studies that it was interesting that of like South American tribes that the incidence of hypertension is very low. It makes you wonder, is it all our lifestyle and stress, and like you said, all these factors that add up that get your blood pressure high?
Right. Yeah, I feel like we probably didn't talk about stress enough. But either way, we'll probably talk about that for a while. I think we're probably getting close to the end here. If there's kind of like some like take-home points you want people to think about, like, do you have anything in mind as like what we're talking about? I think we did a really good job of overlapping, talking about all of the big things. And this is all about education, understanding where you are, understanding what it is when it's a problem, understanding what the strategies are to fix it. And this is a very doable thing for most people. And to kind of help have the guidance, like, to be honest with you, like, most people can have a normal blood pressure without a clinician, right? I'm not telling you not to have a clinician. I'm telling you, like, you have a lot of power here. Having a clinician in your corner to help explain things to you and help you troubleshoot what's going to work best for your lifestyle, I think is important. So do you have any, like, take-home points for us?
I think a major take-home point is one thing that I disagree with the current recommendation is screening maybe every 3 to 5 years. When you're young, like under 40. I mean, talk about catching things like secondary hypertension. I think that's maybe beyond our talk, but there's causes that aren't your fault and may be genetic or some other condition. So checking early, and if you need somebody like a physician, particularly someone in integrative medicine, I think someone like Dr. Saunders is the perfect person that you don't want to avoid someone like me, where maybe you're never seeing me, which is a good thing, but it's what we want in preventative medicine. And then the other couple, another thing another point I'd like to add is making sure you're not doing things that can elevate blood pressure, like certain medications or supplements. Things that may have like Chinese mahuang or ephedra, NSAIDs, particularly ibuprofen, some pre-workout supplements, and other sympathomimetic or increases your sympathetic system can increase your blood pressure. Or yohimbine, which is like a African bark that can maybe used in sexual dysfunction. And then I think the
that's
final
actually become
point,
a lot more popular in recent I'm probably in the last year or two, because a lot of the social media people are saying you have to have a certain number of testosterone, and so people are saying, well, in order to do that, I take something like that. And so, yeah, there's a lot of things that we do unintentionally that might be a concern. So I didn't mean to cut you off, but I wanted to make that.
Oh, no. No, that's a great point. And I remember reading it in our pharmacology book and say, oh, that's not relevant. And only to then find that, yes, it can be very relevant. And I think the final point is, with all this nuances in blood pressure, yes, it's a problem. We need to diagnose it and treat it sooner. Obviously, interventions other than medications first. And then if you do have it based on risk or, other conditions, then, medications plus that can be very helpful and prevent things like strokes, heart attack, and even death.
Yeah, I think death is a good way to end this podcast. So, but no, we want to avoid it. That's the objective.
Or dementia, where you may not remember it.
What's good for the heart's good for the brain. I think most cardiologists will agree with that logic. So,
yeah. Hey, thanks again for having me, Tyler. And one thing to add is, I don't know if your viewers know this, but you personally changed my life for the better. I don't know if anybody knows this, but I was in the wrong direction. I was studying day and night in medical school, and I neglected my health, and I was actually technically in the obese range. And Dr. Saunders, was the one that challenged me on that, and to use exercise and food as a medicine. And I have to say that I still feel like I'm 18. I have all the energy, and it also is a great example for my patients and my children and my family. And you really helped me, and I can't thank you enough.
Of course. All right. Well, then let's bring it home as we can. François, I'm really happy that you were able to join me. This is the kind of conversation I was hoping we would have, that Beyond Normal would create. The idea here is we're thinking about what is normal, and unfortunately, the average person, almost average person, has high blood pressure, and that's not okay. That's not normal, and we want to make sure we're adjusting that. Right, so I want to thank you for your time, bringing your expertise and level of depth to this topic that affects so many people. If there's anything we discussed today resonated with you, or you've never been told you have high blood pressure, or your blood pressure is fine and you're wondering what that actually means, I'd encourage you to take a deeper dive. Here at HealthSpan Chicago, we still are accepting new patients. I'd love to have a conversation about kind of where you're at and ways in which we think about this type of medicine. We do free discovery calls. You can find us at healthspanchicago.com. And before we go, an important note, everything we discussed today is for educational and informational purposes only. It does not constitute medical advice, and listening to this episode does not create a physician-patient relationship. Hypertension is a serious medical condition. Please do not make any changes to your medications or health regimen without consulting your physician. The views and opinions expressed by guests or hosts on this show are their own and do not reflect the official policy or position of any hospital, university, or medical institution. And we'll see you next time on Beyond Normal.